Okay, hi everybody. We have to start, even if we are not all in the room. We have to stick to our time because otherwise we are not going to be able to have the next of our schedule ready. So I would like to introduce Antonis Fanouriakis, which is the Assistant Professor of Internal Medicine, Rheumatology, and it is at the National Kapodistrian University of Athens, Greece, and it is the General Secretary of our National Medical Society of Rheumatology. Thank you very much.
Thank you very much. It's a great pleasure and honor to be here with you. And on behalf of the National Rheumatology Society, I would really like to wish the best for your Congress. I think such initiatives are very, very important and promote also the collaboration between physicians and patients with rheumatic and musculoskeletal diseases. Actually, I don't have any slides. I would like just to say a couple of words to set the stage. As we say, I think we're going to listen to very interesting stuff by our very distinguished speakers in a variety of diseases. But just preparing for this introduction, I was thinking that I think there were three, or there were, I think we're in the verge of probably the third revolution in the treatment of rheumatic musculoskeletal disease. I mean, in the 50s, we had the first use of glucocorticoids in patients with rheumatic and musculoskeletal diseases. It was the first use of cortisone. And I was recently invited to speak in a congress, in a vasculitis congress, and I was about glucocorticoids in rheumatology. And I had, while reading for this lecture, I had come across a very, very interesting story. Maybe some of you know it. It's a story of a famous painter called Raoul Dufy, who suffered from rheumatoid arthritis in the first half of the 20th century. And he was probably actually unable to paint. And at the same time, it was the first experiments with glucocorticoids in Boston by Philip Henk, one of the pioneers in glucocorticoids in rheumatology. And then Raoul Dufy had gone actually there, hoping to find a cure. And he very vividly described how miraculous was the effect of glucocorticoids in his rheumatoid. That was the good news. The bad news was that several years later, Raoul Dufy died from what we believe was obviously side effects from chronic glucocorticoid therapy, because he died of gastrointestinal bleeding due to probably combinations of non-steroidal drugs, glucocorticoids, etc. But still, prednisone and glucocorticoids were a revolution, I think, and we still rely, unfortunately, to it for a significant proportion of our patients. But then I think the second great advancement in rheumatic disease, of course, was the introduction of targeted drugs, biologic therapies in the late 1990s, which, of course, transformed the way we practice rheumatology all over the world. It was patients that, for example, suffered from ankylosing spondylitis for many years. They were in wheelchairs, and by the time they received the first infliximab at that time infusion, they could raise from their wheelchair and could be able to walk again. So I think this was a tremendous advancement in treatments of rheumatic and musculoskeletal diseases. But as I was training in rheumatology, and I think several years ago, 15, 20 years, we had the notion that after the big revolution of the first biologics, the incremental value of new drugs, of course, it's very important to have many drugs, was somewhat moderate or marginal. So we think that, okay, we did the big step, but now we have probably reached a plateau that most new drugs are probably similar to the previous ones. I think now we'll see how it goes, but we're maybe in the verge of a new revolution in rheumatology treatments and treatment of rheumatic diseases with what we call cell therapies, especially in severe diseases that are probably very important, the role of B cells. We see that now with, for example, CAR T cell therapies, or what we probably will hear about, bispecific T cell engagers, so drugs that will cause profound and very deep B cell depletion. We think that we may be able, or we hope that we will be able to treat some of our most serious patients in a more efficient way that we have been able to do until today. So without further ado, I would like to again wish you the best for your Congress. I think our first speaker is George Demirzoglou. George will speak. He's a late-year resident of rheumatology in our hospital. And George is going to start with rheumatoid arthritis. George?
Okay. I just want to introduce.
Thank you. First of all,
Just a second. I want to introduce you. The people know. This is Dr. George Demirozoglu. Did I say good? This is rheumatology resident at Icon University Hospital, Hellenic Air Force Medical Corps.
First of all, I would like to sincerely thank the chairpersons and the organizing committee for their kind invitation. It is a great honor and real pleasure for me to participate in this round table, especially alongside some of the leading figures in rheumatology in Greece. Today, I will share with you some thoughts on the future of rheumatoid arthritis therapy. Where are we now? What the limitations of current treatments are, and most importantly, the exciting new therapeutic directions that are emerging. I have no conflict of interest to declare. So now we are going to see, after a short introduction, current therapies and limitations, emerging small molecules and biologics, cell and gene therapies, precision medicine, and our future outlook in rheumatoid arthritis. So, rheumatoid arthritis is a chronic autoimmune disease with major morbidity. The key immunological players are seen in this picture. T cells, especially T helper cells, initiate and amplify immune responses. Th1 responses with cytokines like TNF alpha promote inflammation. B cells produce autoantibodies and present antigens to T cells. Macrophages are the major producers of pro-inflammatory cytokines and drive chronic tissue inflammation and destruction. Synovial fibroblasts activated by cytokines and T cells proliferate abnormally and secrete enzymes that damage cartilage and bone. And of course, dendritic cells present antigens and activate T cells in the joint and lymph nodes. Currently, treatments include DMARDs like methotrexate, biologic like anti-TNF drugs, IL-6 inhibitors, and anti-CD20 drugs like rituximab, and JAK inhibitors, as all of you know. However, many patients don't achieve full remission, and these therapies have their own side effects and high costs. Up to 4% of the patients don't respond well to biologics. They are so-called difficult to treat patients. There are long-term safety concerns, especially for some categories of drugs that we are not so experienced yet. And of course, high costs also limit access globally. We are going to present to emerging small molecules. Next generation JAK inhibitors are more selective, aiming for fewer side effects. Especially tyrosine kinase inhibitors show promising safety profiles, especially in other autoimmune diseases like psoriatic arthritis, that there is more experience, but there are a promising therapeutic target to rheumatoid arthritis as well. Bruton kinase inhibitors target B cell signaling, which plays a key role in rheumatoid arthritis pathogenesis. In the beginning, preclinical studies showed more promising results, but clinical trials have mixed results. There is an ongoing trial, there is an ongoing phase 3 trial now with everolimus and we are waiting for its results now. For novel biologics, new targets include IL-17 and IL-23 that are already known in other inflammatory diseases. Anti-GM CSF antibodies block a different inflammatory pathway. And although we have already a negative phase 3 trial, I think personally that is a pathway that it's worth to further investigate. And of course, bispecific antibodies may inhibit two pathways simultaneously, and with an acceptable safety profile, as Dr. Drossos and Dr. Vulgari present in their previous review article. We proceed to cell-based therapies and gene therapies. CAR T cells are the most famous and of all. They can target pathogenic B cells. Regulatory T cell Tregs therapy aim to restore immune tolerance. And of course, gene therapy tries to permanently reprogram the immune response, but techniques are still in preclinical stages, and we are not there yet for the treatment. But keep in mind that the ultimate goal is long-term remission without continuous medication here, but we are still far away from this. And I'm going to continue with precision medicine. We are moving toward biomarker-driven therapy selection. Pharmacogenomics main guide drug choice and dosing. And of course, artificial intelligence could help us predict flares and make treatment responses for rheumatoid arthritis patients. The trend now is moving from broad immunosuppression to targeted therapies. The ultimate aim is sustained remission, prevention of joint damage, and potentially even cure. In summary, therapies for rheumatoid arthritis are evolving quickly, moving from broad immunosuppression to more targeted and personalized approaches. Future options, including novel biologics, small molecules, and even cell and gene therapies, aim for safer, more durable remission. The goal remains the same: better outcomes and quality of life for our patients. Thank you for your attention.
Thank you very much, Mr. Dermizoglu. And now, please, Mr. Loukas Hagis is going to present us the future RMD treatments, biologic, etc., for the Sjogren's disease.
Thank you, Katie. Thank you, Igor.
Loukas is very cooperative with Sjogren's. She's a postdoctoral fellow and she's working at the... and he is working at the Department of Pathophysiology at the Lykonosocomio of ECPA. Thank you, Loukas.
Thank you, Katie. Thank you, Igor. We are completely switching gears. I don't know if that was on purpose, but we are going from rheumatoid arthritis, the disease that has like the largest armamentarium of biologic and disease-modifying drugs, to Sjogren's disease, the disease that has zero. And I do not want to waste any time whatsoever because 10 minutes have become far too less to get acquainted with novel treatments in this disease, treatments that are in the line or even on the verge of getting regulatory approval. And this practically stands in sharp contrast to just a couple of years ago when 10 minutes would have been more than enough. And we can see that something important is steering when big news media outlets like the BBC like report on novel drugs for a disease that people are unable to cry. And this is an unfortunate euphemism for Sjogren's disease patient because one of the reasons why finding treatments for Sjogren's disease is such an unsolvable puzzle is because exactly the clinical phenotype of patients go far beyond just being unable to cry. And if we have any patients with Sjogren here, I'm sure they're gonna attest this fact. Patients have non-specific symptoms. They have fatigue, they have arthralgia, they have depression, fibromyalgia. They have the periepithelial manifestations, dryness in the eyes and mouth, that is called the Zika symptoms, that is the cardinal manifestations of the disease. But periepithelial manifestations can go far beyond just dryness and can involve internal organs, the liver, the lung, the kidney. And then we have the systemic form of the disease, an immune complex-mediated disease that usually the immune complexes have cryoprecipitatable properties, and this makes our patient visit the emergency department with severe manifestations such as glomerulonephritis, peripheral neuropathy, and palpable purpura. And another unique finding about Sjogren's disease is that it stands at the crossroads of autoimmunity and lymphoproliferation. And the other reason why we are in big lack of a successful treatment for the disease is that we have a very complex, unique, and partly understood pathogenesis for the disease. What we do know is that, and the current model right now is that in genetically predisposed individuals, factors of the exposome, like a virus, can interact with the salivary gland epithelial cells. And this interaction can induce TLR ligation. Some of the cells undergo apoptosis, and they release some apoptotic blebs in the microenvironment of the salivary glands. These blebs are being sensed by sentinel plasmacytoid dendritic cells and release high quantities of interferon, giving the characteristic interferon signature to Sjogren's disease. The interferons now interact with the resting salivary gland epithelial cells, the neighborhood cells, and they activate them. What does it mean? They secrete cytokines, bringing at the site of tissue lesions B and T cells from the periphery. B and T cells come together and they interact, and B cells form little lymph nodes at the site of the salivary gland. And these structures are called ectopic germinal centers. And from these structures, B cells get more hard and they produce large quantities of high affinity, very destructive autoantibodies. And from the other side, T cells also get activated and they produce lots of cytokines, like amplifying all this process. So all the drugs that are being tested right now for the disease block some pathways in this aberrant inflammatory cascade. But in order to get a better understanding for the complex treatment landscape for this specific disease, we should get a quick look at the history of clinical trials for Sjogren's. So the first period that started at the early 2000s, including the repurposing of the basic drugs for rheumatoid arthritis, anti-TNF, anti-interleukin-1. It enrolled all patients with Sjogren's indiscriminately, and there were no validated primary outcomes. So each trial used its own primary endpoint. All these trials failed. But the second phase emerged after the introduction of the ESS-DAI. And right now we completely changed how we think about the disease, and we focused only on patients with high systemic disease activity. That's the 5 or 10% of the total Sjogren's population. And the primary outcome is the reduction of the ESS-DAI. We repurposed a number of biologics for this disease. And please, I will take the luxury to oversimplify with this cartoon to understand the targets of those treatments. So we used abatacept, stopping the interaction between B and T cells. 2 large randomized trials, mainly supported by the Netherlands, by Henrika Buchman, and the USA, Alan Baer, completely failed. We tried rituximab at the CD20. Many clinical trials, the largest being the TRACTIS and the TIARS from the United Kingdom and France. They couldn't show difference in the treatment arm compared to the placebo. We followed the paradigm of lupus, and we tried belimumab in the BELLIS trial. Again, we couldn't see any benefit with treatment, or even the sequential giving of rituximab and belimumab could not differentiate the treatment arm and the placebo. So all treatments failed in the second phase of Sjogren's disease. But this paved the way for the third phase, in which we stand today. And in this phase of Sjogren's disease treatment, we have novel drugs, not the repurposing of other drugs, that are much more oriented in the intricacies, in the special things of the pathophysiology of Sjogren's disease. We have larger trials, and the strategy that we use is kind of different. We use the umbrella design that is practically like conducting 2 trials in parallel, under the same framework, and they have a difference in the inclusion criteria that are mutually exclusive. So in this phase, we have tried ianalumab. It's an antibody against BAFF receptor. Why BAFF receptor and not at the CD20 receptor? BAFF receptor is largely expressed in B cells compared to CD20. So the antibody perfectly depletes all circulating B cells, but also some of the plasma cells and plasmablasts, in the bone marrow. So we get a little bit more of the B cells. It also interferes with the recirculation of B cells. We know that after rituximab failure, we have a very early repopulation of B cells. So this is stopped with ianalumab, and we also abrogate the levels of an important cytokine called BAFF that is very important for the survival of the B cells. But we can also take like the high road that leaves B cells intact but block their intracellular signaling with remibrutinib blocking the BTK. BTK is also expressed on mast cell, basophils, and macrophages. So this is important because it modulates the microenvironment of the inflammation that seems to be important. And lastly, we can also block the territory of the CD40 ligand, very important interaction between B cells on the left and T cells on the right. We can block the CD40 with iscalimab, and with a fusion protein called dazodalibep, we can block the CD40 ligand. So all these trials had the first thing for Sjogren's disease. They met the primary endpoint, that is a reduction in the ESSDAI. What is something important to be noted is that the dose response was not always present, especially in the iscalimab trial, it is obvious, and the ianalumab trial. What is also very important, and we should always care about, is the ESSPRI. ESSPRI is a composite index of how the patient feels. None of the trials improved how the feelings of the patient, with the exception of dazodalibep, the only drug that has proven efficacy, reducing, at least for 2 points, all domains of the ESSP, dryness, fatigue, and pain. The last kid on the block is nipocalimab that really is being, uses the effect on the most downstream level of the inflammatory cascade by blocking the recirculation of the autoantibodies. These are not really published, but are released in the latest ACR. We can see that with the largest dose of nipocalimab, there is a big reduction in the ESSDAI, and again, this is not correlated with a reduction in the ESSPRI. So where are we now? And just to wrap things up, this is a race for approval for all these drugs. A few days ago, I think nipocalimab was leading the way because it has come in contact with the FDA 6 months ago based on the phase 2 DALIAS results, and we are waiting for the phase 3 result. Dazodalibep was just behind. Dazodalibep is the only drug that has improved the sensation of the patient, so generalizability of the results are better with dazodalibep. Ianalumab has proven sustained efficacy, and way behind is remibrutinib and iscalimab. Remibrutinib, ianalumab, and iscalimab are all made by Novartis, who have focused more on ianalumab. This changed just a few days ago, when the results of the Neptunus 1 and 2 trials were released, not released, a report was released by Novartis that both the Neptunus 1 and 2 trials met their primary endpoint, that is reduction of the ESSDAI, not reduction of the ESSPRI. So Novartis and ianalumab have granted fast track designation. So in the next couple of months, we will see a full file being submitted to the FDA for the approval of the drug. I would not get very enthusiastic about all these treatments. Don't forget that these treatments make the doctor feel happy. The ESSDAI goes down. That's a composite index with many lab values, with the assessment of the doctor, but most of the drugs don't make the patient feel better, and this is the ultimate goal for the treatments. So we're going to see the real-world effect in the next couple of years. Thank you so much. Thank you for inviting me.
Thank you, Dr. Lucas. Now I would like to introduce Dr. Stelianos Panopoulos. It is rheumatologist commissioned lectures, propedeutic and internal medicine department, medical school, University of Athens.
Thank you, Mr. Chairman, for the introduction. Welcome all. Thank you for the invitation. It is really honored to be here. So in the next 10 minutes, we will talk about the future of treatments in systemic sclerosis, and I will start with a brief introduction for those of you who don't know what systemic sclerosis is. It is a prototype fibrotic disease, a very rare autoimmune disease, mainly in females, and the main characteristic is an excessive production and deposition of collagen in the skin and the internal organs, resulting in thickening and fibrosis and, of course, malfunctioning of the lung, of the hearts, of the esophagus, of the vessels. It is a disease with a highly variable clinical spectrum, from minimal fibrosis to excessive fibrosis. And according to our experience, the organs that are mainly affected are the lungs, with the development of lung fibrosis, the esophagus, and of course the vessels, with the development of pulmonary hypertension and digital ulcers. So it is a disease with a high impact in daily life. It has an increased morbidity. It has functional limitations in daily routine because of the dyspnea or the pain or the contractures, increased absenteeism and presenteeism, and unfortunately reduced survival. And it is characteristic that it is a disease with the worst prognosis among all other rheumatic diseases, even systemic lupus erythematosus, vasculitis, or rheumatoid arthritis. So it is a potentially severe disease, so we need effective treatments. But in order to treat, we have to know what is the enemy. And very briefly, in the pathogenesis, we can discriminate three axes. There is autoimmunity with inflammation, there is vasculopathy with damage of the vessel wall, and of course there is fibrosis due to the excessive deposition of collagen, and these three axes interact each other. So the goals of our treatment strategy is to reduce inflammation, is to improve vascular circulation and reverse vasculopathy, and of course to inhibit or attenuate fibrosis. And according to the recommendations that we have from the European League Against Rheumatism, we treat vasculopathy with vasodilators, we treat inflammation with immunomodulators or immunosuppressives, and we have the last 5 years also we have the first antifibrotic agent, nintedanib, to treat fibrosis. And during the last 10 to 15 years, there is major progress in treating systemic sclerosis with new, more potent vasodilators. You can see 3 different categories of these drugs. And we have better results in treating pulmonary hypertension and digital vasculopathy. We have new, more potent immunosuppressives, and we have two new biologic agents, tocilizumab, which blocks interleukin-6, a major cytokine in the pathogenesis of systemic sclerosis. And this drug reduces inflammation and reduces the decline of lung function. And also we have rituximab, another biologic agent that blocks B cells, and also it slows down skin fibrosis and lung fibrosis. And of course, we have the first antifibrotic agent, as I told you before, the last 5 years, nintedanib, which is effective in slowing lung fibrosis. And for some selected and very severe, rapidly progressive cases in the early stages of the disease, we also have the alternative of autologous stem cell transplantation. It is a procedure in a way to reset the immune system. It may change the natural course of the disease with potentially long-term benefits, but of course we have also to take into account the high risk for serious adverse events. So are we happy with all this? Compared to the past, yes, we're happy, but of course there is also many things that we need to improve because several patients are refractory to the existing available treatments. There are side effects of long-term therapies, and of course there is no definite cure yet. So there is need for more targeted and safer treatments. So what lies ahead? The first is that we have a shift in our treatment strategy. We have started combining different immunosuppressives because by blocking simultaneously different molecular pathways, we increase the possibility to attenuate disease progression. So by hitting the disease by different sites, we have better outcomes. And I will show you in the next 20 seconds some results from one study that we had in our center. In 20 patients with refractory disease, they were treated with double or triple combination therapy. And after 1 year of treatment, we had stabilization of lung function in these patients, and we had no progression of lung fibrosis in computed tomography of the chest. And also, there were no serious adverse events. So it is a strategy that it is more efficient, it has a good safety profile. Do we have any new agents? Yes, we have 2 new biologic agents. The first one is sotatercept. It is a biologic agent that inhibits the molecular pathway that results in the damage of the vessel wall, what we call vascular remodeling. So it preserves blood circulation, and it is an approved therapy for pulmonary hypertension. And also we have nerandomilast, a new agent with both antifibrotic and immunomodulatory properties, which has shown efficacy in preserving lung function in patients with progressive pulmonary fibrosis, including patients with systemic sclerosis. And it has shown efficacy even in patients who had not responded to the other antifibrotic nintedanib. So we have two new agents that are approved for systemic sclerosis. You've heard previously Dr. Dermizoglu. He mentioned cell therapies. There is a lot of hype for this procedure. What is CAR T-cell therapy? It is a procedure where genetically engineered T cells specifically target and destroy autoreactive B cells that are involved in the autoimmune process. The preliminary results from clinical trials are very promising. Potentially, there is long-term remission. Like autologous stem cell transplantation, it seems that there is a reset in the immune system. But again, we need more data and we need more time to validate the results and also to make sure that this procedure is safe for the patients. And of course, there is growing research, at least 15 to 20 new biologic agents that block cells or mediators that are involved in the pathogenesis of systemic sclerosis are currently under research in clinical trials, phase 2 or phase 3, and we are very optimistic and we hope that in the next years, some of them will reach the end and will be approved for the treatment of systemic sclerosis. I will end my presentation with 2 slides. The first one you've already heard. There can be no future without precision medicine. And what does precision medicine mean? It means personalized, individualized therapy to achieve better outcomes. And how are we going to achieve this? By finding biomarkers and genetic biomarkers that will predict better treatment response. We will be able to find the best drug for each patient. And this will be easier to achieve also with the help of artificial intelligence. And of course, other technologies, mobile applications and telemedicine to improve our communication with our patients and to follow them in a better way. And last but very important, we have always to keep in mind that we have to put our patient in the center of all this procedure. And we have to apply a holistic approach. It is very important not only to care for the physical, but also for the mental health of our patients. Rehabilitation, exercise, emotional and social support are very important. And I would like to note that from your side, it is very important to contribute in our research. We need you to have data to shape our design. And also, it is very important that you take part in these clinical trials because you are the key to find future treatments. To close my presentation, the management of systemic sclerosis is rapidly evolving, and we are moving from several limitations to a future with more and better therapeutic options. There is a major progress in the last 15 years with new, more potent agents that are available. Combination treatments is a strategy that we have to apply because it is more efficient and it is safe for our patients. Many new targeted therapies are under research, and precision medicine and patient-centered care are very important to improve outcomes. So thank you very much for your attention, and I would like to tell you that together we will shape the future of systemic sclerosis.
I would like to mention that in Israel, we do CAR T-cells for
Yes. Yes, that is very hope. Okay. Nice to hear that.
Thank you very much, Mr. Panopoulos. And now we would like to invite Professor Boubas, which is a director also at Attikon Hospital, the Rheumatological Clinic, and also associate member of Biomedical Research Foundation Athens Academy, who is going to present us and tell us about lupus. Thank you very much, Professor Boubas.
Welcome in Athens. Athens is a wonderful city, but the traffic is not easy. So I apologize for being late. I made a mistake to go to work in the morning. I'm delighted that you're here. This is a wonderful opportunity that came evolved in Southern Europe, and I see that it's maturing year by year. I will tell you a few things about lupus. I'll try not to bother you with too much information. I'm getting older, and I'm learning the beauty of being simple and hopefully not simplistic. If you like to target lupus, you have to target one of these key pathogenetic events. In lupus, you have excessive, aberrant activation of cells. We think that the T cells and B cells are the key, but also dendritic cells, and more recently, neutrophils and macrophages. And how do you do this? You can delete them, like with rituximab or obinutuzumab. It's more another monoclonal antibody that we borrowed from oncologists. We used to do that in my days with cyclophosphamide, which was a wonderful drug, but had side effects with sterility. And you can delete them with the CAR T cells, as you have already heard. Or you can inhibit their action. And these are the two drugs that can inhibit the action, is the abatacept or the anti-CD40 ligand antibody. In lupus also you have defective function of T cells that police the aggressive activated T cells to produce this autoimmune phenomena. There are a couple of studies suggesting that low dose interleukin-2 may be useful in lupus, but I'm not sure that this is going anywhere because but increasing the function of the policing, the regulatory T cells is still an option in lupus. And finally is to decrease the production of pathogenic autoantibodies and also inflammatory molecules. Some of these autoantibodies, once they're produced, now there are new treatments that promote their degradation by inhibiting a natural molecule that exists that prolongs their half-life. You can inhibit cytokines like an interferon. You see, we have a drug approved like interferon alpha, but that's for general lupus. We have complement inhibitors in vasculitis. Complement is an inflammatory molecule, and that there are trials in lupus evolving, or inhibiting the cytokine action with the kinase that people are using also in rheumatoid arthritis, as Dr. Dermizoglu suggested. Let me just, I would like to be a little bit more specific, and I decided to focus in the lupus nephritis. This is because we're about to publish the new recommendation for the treatment of lupus nephritis, and I would like to use that as an example to highlight some of the challenges, but also the achievements and the future perspectives in this disease. This is a disease that used to kill patients with lupus. The IV cyclophosphamide made a big difference, pioneered by NIH. Then the MMF mycophenolate was introduced, and that was a big plus because cyclophosphamide has problems with sterility. And also the tacrolimus, what they call calcineurin inhibitors. Altogether, in the last 10 or 15 years, the addition of MMF and the use of these drugs has improved the prognosis of lupus. However, 1 in 5 lupus patients do not achieve complete renal remission, which is important if you consider that these are young women, and if you're not in complete remission, you have an increased risk after 15 or 20 years to have problems with your kidneys. 1 in 3 patients have relapses after after decreasing the therapy. And also in Northern European countries is 1 in 5 lupus patients. In Southern European countries, at least in our data from multi-center registry that the Greek Society of Rheumatology has, only 1 in 5 patients reach end-stage renal disease after 10 or 15 years. So we're much better, but we still face some challenges. So, because we understood better the pathogenesis of lupus over the last 20 years, I should say, we have tackled the pathogenic anti-DNA antibodies, lymphoid cells, cytokines, or co-stimulatory signals. These are some of the molecules that they were tried in clinical trials. Some of them initially were successful, but most of them they were unsuccessful. And these drugs, although very promising, never reached the market. And that was a little bit disappointing and frustrating, but we did have some successes, and these successes came unexpectedly. In the case of lupus nephritis, Benlysta, a drug that had rather modest effects, is not a very heavy immunosuppressant, has immunomodulated immune response, but it doesn't kill cells. That was shown to be effective, and then voclosporin, a better formulation for calcineurin inhibitors such as tacrolimus, but also more recently the obinutuzumab, this monoclonal antibody that kills B cells. There were trials in major journals, and altogether they showed high rates of complete renal responses. So we did improve, by 10 or 20% the renal responses. We have decreased by 50% the relapses, but most importantly, and it's very important for young women who have a lifelong to live with lupus, we managed to taper aggressively the steroids, and now the goal of the therapy is to, after the first year, to stop the steroids. And these drugs have allowed us to do this. And the toxicity was, thank God, acceptable. So putting this together, the experts from all over the world, nephrologists and rheumatologists, they got together, and Fanougiakis Antonis, who is here, has prepared this manuscript, which is based on experts' opinion, but also on data. And this is it's about to be published next month. And so we have, in addition to the new drugs that I told you, that we are using better strategies to have better results. And these are, for example, in these recommendations, we decided that it's important to use combination of all available drugs for all patients, and not to try to see patients who may because that makes sense. It's, if you have a bad disease, you need to put it in remission. The sooner, the better. And in some patients may not need it, but it's better to offer this option to all of them. We have decided that if you use pulse steroids, high dose of steroids intravenously, that's a very effective therapy. We have shown that from NIH more than 30 years ago, better efficacy and not increased toxicity, and that allows you to taper more aggressively the steroids. The tacrolimus, this is drug that in the older recommendations, we were rather skeptical. We wanted to see more data, and we moved it up, and now you can use it from the beginning. Also, we have seen and have decided that the longer you treat, at least 3 years, the better it is. We have fewer relapses, the better the results, with acceptable toxicity. There is a form of lupus nephritis that the nephrologist, because they had experience with idiopathic membranous, that they were underestimating. We moved it up front, and we said that you have to be aggressive early on, and that's included. And also something else that we have introduced is that the protection of the kidneys, what we call the nephroprotection, and these are some drugs they can do, but also blood pressure. And so this better medical management is reflected in these recommendations. But also, as has been already highlighted in this meeting, is you need better care. The drugs are not enough. And better care is early detection of kidney involvement. Now, we in Europe were much better in early recognition and doing the biopsy earlier. The precision medicine has been discussed. We don't have any major breakthroughs in lupus, but we have initial data suggesting that eventually we'll reach this target. We need also some other biomarkers for the early identification of poor responders. And here I would like to bring the issue of the liquid biopsy. The oncologists use the liquid biopsy to avoid the biopsies. There are some data suggesting that the liquid biopsy may be possible in the next 5 years with lupus nephritis, and that will allow you to have a better feeling how well the kidney does. And also, another important issue is because there are many countries in the world that these medications are not available, is the worldwide availability. As a community, we have to think of things like other rare diseases, like the hemophiliac are doing. There's a coordination of patients and industry that they have a fund and they make some treatments available which are expensive for less privileged countries of the world, and that would be an important role because many lupus patients live in countries that they cannot afford these expensive medications. And let me finish up with the new drugs. You heard about this hype with the CAR T therapy. I'm not sure this is this could be like a treatment for many patients with lupus. But what it really shows that if you kill all the B cells effectively, that can put you difficult lupus into remission. But we have to find cheaper and better ways to do this. There is an anti-interferon trial. There is anifrolumab is available for general lupus. And there is a trial that I show here that's ongoing for lupus nephritis. Now, there are other trials using monoclonal antibodies either to delete, like this anti-CD19 antibodies, more effectively delete the B cells, and also an anti-BAFF antibody, which we hope that will be a little bit stronger than Benlysta. Other molecules that you see here are about to start. We use borrowed drugs used in other diseases or for multiple myeloma, or a new anti-CD40 ligand that we have first used 30 years ago. And let me finish up with this new hype, which is the BiTE, which the feeling is that at least from the leukemia lymphoma field, is that it may be better even than the CAR T cells that the previous speakers suggested here. And let me show you what are these BiTEs. The BiTEs are monoclonal antibodies that bring together two types of cells. The bad cells, which are in the upper part, these are the T cells that could help you, and the bad cells, which are pathogenic cells, which are in the lower part. Use this molecule to bring them together, and then you help the T cell to kill only the bad cells, those bad cells that you like to target. And so these antibodies, they are more effective in killing. They are not so difficult, not so expensive. They are not as toxic as the CAR T cell therapy. And there are, as Yorgos Dermizoglu suggested, there is a molecule that has been tried in refractory arthritis. This is CD19 BiTE. In rheumatoid arthritis, we have more experience, but there is a report using this monoclonal antibody, which is called teclistamab, which brings together the T cells with the pathogenic B cells, the T cells recognized by the CD3 part, the BCMA, the pathogenic B cells by the other part. They bring them together, they kill them, and that put in remission in a refractory case of rheumatoid nephritis. This is not to say that they have the promise. We have a long way until they reach the patients. But for most patients, and I would like to close by that with lupus, we have managed to improve the prognosis, to significantly decrease the steroid use, and the side effects from the steroid to limit the damage. We have drugs now that they can help even the fatigue, like Benlysta, something that was very difficult to manage before these biological agents. And we have much better results than what we had a few years ago. But you need better care, and this is it's not just the drugs, it's not just the doctors or the patients. You need more people to be involved in this process, and certainly this meeting brings all these partners together. This is my reporting for lupus.
Thank you. I would like to introduce Dr. Vlachoyanopoulos Panayotis. It is a specialty in rheumatology, Director Department of Rheumatology, Athens Medical Center, Assistant Professor of Medicine, Columbia University, New York. Welcome.
Thank you very much. I was asked to discuss this issue, advances in the treatment and research regarding axial spondyloarthropathies. So, spondyloarthropathies are a spectrum of diseases which are depicted in these slides, such as ankylosing spondylitis, psoriatic arthritis, reactive arthritis, heteropathic arthritis, juvenile, and undifferentiated spondyloarthropathy. All these diseases have a major characteristic, the axial skeleton involvement, also sacroiliitis, fusion of bones, extra-articular periostitis, babu spine, but also skin involvement, gut involvement, enthesitis. Enthesis is the connective tissue between tendon or ligament and the bone, and also bursitis. Bursa are small fluid-filled sacs that act as a cushion between bones, tendons, and muscles, facilitating smooth movement, and also eye involvement such as uveitis and dactylitis. Here you see enthesitis, especially in the tendon, Achilles tendon, and also the plantar fascia. And you see tendinitis here in the tendon of Achilles, and also dactylitis, penicillin cap malformation due to involvement of the distal interphalangeal joints, and also dactylitis here. And of course, sacroiliitis, which is a cardinal feature of axial spondyloarthropathies, and you see several stages of disease until complete fusion of sacroiliac joints, the disappearance of the joints. Extra-articular periostitis is depicted here, and also, as all of you know, bamboo spine. So axial spondyloarthropathies are the result of inflammation, repair, and new bone formation. Inflammation is depicted here, real cases on the top, and cartoons on the bottom. Inflammatory affection of the bone marrow in axial spondyloarthropathy, bone marrow edema and osteitis on MRI, normally detected by MRI STEER sequence. Here, however, there is a repair process characterized by bone marrow replacement by granulation repair tissue that might appear, not always, however, as fatty lesion on MRI, and finally, new bone formation, which starts in the areas of active repair that gives rise to syndesmophytes, which make the bamboo spine. So, therapy, the goals of therapy lie on these general principles. First of all, we have to relieve the symptoms, maintenance of function, prevention of progressive structural damage of the spine, minimization of extraspinal and extraarticular manifestations and comorbidities, and maintenance of effective psychosocial functioning. Initial therapy includes non-pharmacologic interventions such as patient education. The patient has to have lifelong exercise and belong to a posture training program. It has also to obtain habits relevant to axial spondyloarthritis, regular follow-up and management of comorbidities, and patients should be instructed about the medications, potential side effects or therapies. The patient has to stop smoking cigarette. Patients should undergo screening for anxiety and depression by a psychologist at the beginning, and exercise improves health-related quality of life, cardiovascular fitness, and the disease activity in these patients, and we have to encourage these patients to do that. And also, initial therapy. We all work in tertiary care centers, and the patients come to us after seeing many doctors. However, initial therapy with non-steroid anti-inflammatory drugs has still a place in the therapy of these patients. As you see, many non-steroidal anti-inflammatory drugs, once a particular NSAID has been determined to be effective within 2 to 4 weeks, then some experts recommend to use it on demand according to symptoms. Therapy in patients with inadequate response to NSAIDs is included in this slide. Many experts suggest that we have to start with a TNF inhibitor, and you see all TNF inhibitors there, and also alternatively specific respective biosimilars, or an interleukin-17 inhibitor, and we now have in the market 3 of them, secukinumab, ixekizumab, and bimekizumab. And of course, we have to explain to the patient that there are some contraindications of TNF inhibitors, such as active infection, latent tuberculosis, demyelinating disease, moderate to severe heart failure. Adverse events of TNF-alpha inhibitors are, the probability is very small, and contraindications of interleukin-17, active infection, and mild to moderate infections, including candidiasis, as adverse events of interleukin-17. Janus kinase inhibitors, JAK inhibitors, are the other drugs which we can choose, but not at the beginning, as many experts say. Advantages relative to these drugs: taken orally, kept in room temperature. We know today 2 of them, upadacitinib and tofacitinib, and the contraindications of these drugs are active infection, prescribed with caution in patients more than 50 years of age, increased cardiovascular risk, malignancy, thrombotic risk, and pregnancy. Inadequate response or intolerance to initial biologic or targeted synthetic DMARDs may make the doctors to use some alternatives. I will skip what primary failure and secondary failure means. The thing is that in the first case, after following 12 weeks of therapy, active disease is considered as primary failure, or if the disease comes in remission and has a relapse, this is a secondary failure. In these cases, we have to switch biologic from one to another, and 3 types of switch is switch to another TNF, switch to another interleukin-17, or switch to a Janus kinase inhibitor. Failure to multiple TNF and interleukin-17 inhibitors also is a possibility, and in that case, there is little evidence and no randomized trials available. Switch to a JAK inhibitor probably. In general, the frequency of good responses to TNF inhibitors is still substantial, but decreases with the use of a subsequent agent compared with the first, and evidence for switch after switch for interleukin-17 inhibitors is limited. The patient may be resistant to all these standard therapies. In that case, abatacept, tocilizumab, ustekinumab, risankizumab, apremilast, and you see the way of action of these drugs can be chosen, although the success is not 100%, of course. Even rituximab we can use in these cases. In all these cases, we have to evaluate the patient for a good monitoring. Bath ankylosing spondylitis disease activity index is a simple way of evaluating patient, and I'm not going to go into detail on that. And also ASDAS is another way of evaluating this kind of patients using calculators which are available in the web. Duration and tapering of therapy, limited data. Tapering TNF-alpha inhibition therapy, some patients seem to respond well. However, this is not a validated procedure. Discontinuing TNF inhibitor therapy, in one study only 25% of patients remained in remission for 40 weeks after stopping therapy with etanercept. A tapering of ixekizumab, yes, ixekizumab can be safely tapered in patients who respond to initial therapy with this drug. After 24 weeks of treatment, 83% of patients versus 55% of patients in placebo remained in remission after tapering. Surgery is sometimes the end result of a worse outcome, and of course, severe hip replacement with persistent pain or limitation in mobility, atlantoaxial subluxation with neurologic impairment, and severe flexion deformities which impaired ability to look in a forward direction are the reasons for surgery. And to conclude, axial spondyloarthropathies are inflammatory multisystem diseases affecting axial skeleton and peripheral tissues, are developed with a process of inflammation, repair, and new bone formation. Cytokines such as TNF-alpha, interleukin-22, interleukin-23, interleukin-17, as well the transcription factor JAK play key roles, and inhibitors of these cytokines and transcription factors seem to be very important to treat the disease. Thank you very much.
Thank you very much, Professor Vlachogiannopoulos. And now, please, Professor Fragoulis, who serves at the first department of Prepedeutic and General Medicine at Laiko Hospital, we're going to speak about psoriatic arthritis.
Thank you very much. Thank you very much for the invitation. First of all, it's a great honor and pleasure to be here in this meeting. That it is in the core of the collaboration between clinicians and people living with rheumatic diseases. We are all fighting the same enemy, aren't we? So I will try to be brief because we are a little bit behind the schedule, and I will try to be simple. So I will speak about the future in the treatment of psoriatic arthritis. And as other speakers have said, rheumatic diseases most of the times are multisystemic. So psoriatic arthritis, it affects about 1% or a little bit less of white Caucasian people, and usually it comes after psoriasis. Actually, 30% of patients with psoriasis will develop psoriatic arthritis in the future, and it affects equally, let's say, females and males. Psoriatic arthritis, as most of rheumatic diseases, is quite heterogeneous. As you can see here, it can affect the joints in multiple ways, like asymmetric oligoarthritis, polyarthritis, like rheumatoid, affecting axial disease, etc., etc. But it's not only arthritis, it has also some other features like enthesitis. You heard what is enthesitis by Professor Vlachogiannopoulos, and it can also cause dactylitis, which means like we say that sausage fingers, and also it can affect the nails. But is it only that? No, psoriatic arthritis has some extra-articular manifestations like inflammatory bowel disease in about 5% of the patients or a little bit less, and eye involvement in about 3 to 4% of the patients. But it also has some comorbidities. Usually, comorbidities in the spectrum of cardiometabolic disease like diabetes mellitus, like obesity, like hypertension, or other cardiovascular diseases, and also some comorbidities in the spectrum of mental health disorders like depression and anxiety, which is a quite common problem in the setting of psoriatic arthritis. Of course, I will not go in the pathogenesis of psoriatic arthritis, but this is a slide just to show you that in the center of the pathogenesis of psoriatic arthritis are some cytokines, and as you know, cytokines are the molecules by which the cells interact one to each other. So what we have here, we have interleukin 17, interleukin 22, TNF, and interleukin 23. So as you can imagine, most of our treatment are against these molecules, against these cytokines. So you see here that we have a lot of treatment for psoriatic arthritis. So we need both new strategies, not only new treatments. But anyway, we will focus today in the new treatments for psoriatic arthritis, which are basically the new interleukin 23 inhibitors, the dual interleukin 17 inhibitor, and the JAK inhibitors. So let's see what we have. First of all, let's say that to choose treatment for psoriatic arthritis is not always easy because, as I said before, there are many different manifestations, including extra-articular manifestations and comorbidities. And this is a table we produced a couple of years ago with Dr. Yalouri and Dr. Evangelatos, which shows the efficacy of various treatments for psoriatic arthritis according to their manifestations. So you see here that you have to be a little bit wise, let's say, and to discuss with the patient to choose the right treatment. So let's see about the new anti-interleukin 23 drugs. So up to 5 years ago, we had ustekinumab, which was monoclonal antibody against the P40 subunit. So you see here that P40 subunit, it is shared between interleukin 12 and interleukin 23. So ustekinumab blocks both interleukin 12 and interleukin 23. But now we have some new monoclonal antibodies, some new drugs, that they target only the P19 subunit, so they are more specific for interleukin 23. So we have these 3 new drugs, you heard earlier as well by Professor Vlachogiannopoulos, and they have some benefits. So you see here that for skin, the green color is a bit deeper compared to the other drugs, along with interleukin 17 blocker. So this means that both interleukin 17 and interleukin 23 blockers are a little bit more effective in the skin compared to the other drugs for psoriatic arthritis. And you see here that they cover a wide aspect of the manifestations in psoriatic arthritis. And here is just a meta-analysis just to show that, as you see here, interleukin 17 inhibitors and interleukin 23 inhibitors are more effective in the skin compared to TNF inhibitors in psoriatic arthritis. And what else advantage they have? It seems that they are a little bit more safe compared to other biologic drugs. So here is another meta-analysis which shows that in psoriatic arthritis, interleukin 23 inhibitors demonstrated less rate for infections compared to other biologic drugs. And what else they can do? It seems that they can intercept disease. So what does that mean? So you see here that in some EULAR recommendations for progression from psoriasis to psoriatic arthritis, it says here that certain treatments may reduce the risk of transition to psoriatic arthritis. So this is a concept of disease interception. And here is just a study which showed that in patients with psoriasis, patients started either interleukin-23 inhibitors or TNF inhibitors, and people started interleukin-23 inhibitors demonstrated less risk to develop psoriatic arthritis or developed psoriatic arthritis at a later time point. So it seems there are some data, some other studies as well showing these things, that interleukin-23 inhibitors may reduce the risk for transition from psoriasis to psoriatic arthritis. Next, we have the dual interleukin-17 inhibitor. You see here that we have many interleukin-17s, A, F, B, C, D, and E. A and F are the most well characterized. So until now, we had drugs against interleukin-17A, but now we have another drug which is against interleukin-17A and F. So it's a monoclonal antibody which blocks both interleukin-17A and F. And what does that mean? It seems that maybe it's a little bit more efficacious in arthritis compared to some other biologics. We don't have strong data so far, but there are some data. So this is just an initial study showing that this new drug, which is called bimekizumab versus interleukin-23 inhibitor, it might be a little bit more efficacious in terms of arthritis as we measure it with ACR 50 and 70. And this is along the same line, bimekizumab against ustekinumab. We have basically the same results. I will not go in detail because we don't have time, but the rationale is the same. And what about JAK inhibitors? So what are the JAK inhibitors? We heard some things from Professor Vlachogiannopoulos. So the JAK are the molecules that mediate the signal from cytokines to the nucleus of the cell. So they just they are, let's say, like mediators. So we tried to block these molecules. We tried to block JAK inhibitors because some of the cytokines, they use these molecules to mediate their signal. So we have some new drugs, JAK inhibitors. JAK inhibitors, they have been used in many rheumatic diseases, including rheumatoid arthritis. We heard earlier, psoriatic arthritis and axial spondyloarthropathies. And they have some benefits as they cover a wide spectrum of psoriatic arthritis manifestations. They have some problems as well, but not huge problems. As Professor Vlachogiannopoulos said, we have to be a little bit careful in patients who have increased risk for thrombosis, but the signal is very low. So we have the new JAK inhibitors, and some other JAK inhibitors are also coming, like this one, the defgrafassatinib, which blocks a specific JAK inhibitor, specific JAK, which is called TYK2. And here you see that this molecule is quite effective, is better than placebo, of course. So we have some initial data to say that this new drug will be also effective as the other JAK inhibitors are. And a couple of slides before I finish my presentation. We don't have only new drugs, but we have some new ways to deliver our drugs. So we have the nanobodies, which are not antibodies. So far, we have monoclonal antibodies. Our biologic drugs, most of them are not JAK inhibitors, but all the other biologic drugs are monoclonal antibodies. But now we have the nanobodies, which are smaller in size and are better for tissue penetration. They have superior stability, and they are easier and cheaper for production. So in the future, we will see this kind of drugs, the nanobodies. And just as an example, we have a sonelokimab, which is a novel interleukin-17A and F inhibiting molecule via nanobodies. And you see here again that it's very effective compared to placebo, but also compared to adalimumab. And finally, I'm sure you have heard many things about the anti-obesity drugs, the GLP-1 receptor agonists. So these drugs, they fight obesity, and they're fantastic. They're very efficacious against obesity, but it seems that they have some good outcomes for patients with rheumatic diseases. it seems that they offer some additional benefit in patients with rheumatic diseases. And some pharmaceutical companies have seen that, and they develop trials that they combine biologic treatments like interleukin-17 inhibitor with these drugs, and we'll see the results in the future. So in summary, we have new drugs, we have new therapeutic targets, we have better methods of delivery like nanobodies, and of course, in the future, we might see new strategies like disease interception or combination of biologic drugs, as we heard earlier. Thank you very much for your attention.
So I think we're just having a couple of minutes for questions. Do you want to do a reallocation? Yeah. Do you have time for this? Okay. Until we rearrange here the seating. I would like to thank all speakers, I think, for providing very valuable insights for what they believe will come up in the near future. I think we're living in promising eras. So we just have time for a couple of questions, but I think it's a unique opportunity, I think, for you to ask our speakers here things that you are interested in. Please. Do you need a microphone? You do need a microphone.
Thank you. Hello, everyone. I'm Nadia Maliou. So in this conference, I'm representing Pain Alliance Europe. I'm the president, but also I am the vice president of Eleana, Hellenic League Against Rheumatism. So my main question to all of you, so thank you for your amazing presentations with the time ticking on your hands. I've heard about innovative medicines, the need for our participation in the clinical trials to help you and the researchers to even find more and reach more outcomes of better and more effective medicines. My question is that even though we do have medicines coming out and in the pipeline and new innovative medicines, we still have patients not in remission or not in low disease activity, or for your perspective in low disease activity, but for our perspective, not. So we are still in pain, we still live with fatigue, high levels of fatigue, not sleeping well, not being able doing our chores. So we come to you, you find us in extreme, nicely indexes of low inflammation indexes, but we still experience pain. We still have the fatigue element in our lives. So what's missing? What do you think is missing? Thank you.
50% of patients having a biologic after 5 years will be in a position that this biologic does not work. This happens because the immune system has a redundancy phenomenon. When we block one way of disease action, the body finds other ways and uses other pathways to express again pathology. The first is this. The second is that every patient is different from another patient. So we have to do more work to see in detail inflammatory processes in all these individuals in order to tailor any drug to any patient. That's why things happen just as you described. However, sometimes I cannot understand much more difference in the way we evaluate the patient and the way the patient evaluates herself or himself. If this happens, all of us lose something. For instance, fibromyalgia is a disease which is a comorbidity of all these organic diseases, and fibromyalgia may be important to understand phenomena related to the patient, to a particular patient. And finally, long-term disease, even with low-grade activity, has, as a result, after many years, degeneration of tissues, and then this degenerative process is expressed with pain and discomfort. So these are, processes which have to keep in mind when we have to answer questions like this.
Great, thank you. I think that in the interest of time, we need to stop. Or can okay. So you decide when we're. All right. So Lucas, please, and then one more short question so that we.
Yeah, I think Professor Vlachogiannopoulos just said everything. Just to summarize, I think there is a gap. There is a gap in what we measure as success and what you feel as success. And this is blatantly evident in Sjögren's when we are happy with new drugs in the pipeline, but we don't really make you feel better. And we should never forget why we do what we do. We do it for two reasons: make you live longer, but that's okay in autoimmunity, and make you feel better. We just don't want our metrics to get better. We want you to feel better. And there is a gap. We are trying together, and this is a collaborative effort to reduce this gap. The reasons for this gap are many. Damage accrual is one of them, as Professor Vlachogiannopoulos. Some things just can't get better. But there are some things that may get better if we understand the disease better. So this is my comments on your very, very important point. Thank you.
Thank you, Luca. Any other short question so that we... No? If I were to make a final comment, I think to link also this session with the next lecture by Professor Sidiropoulos, I think we might end up in the following years having multiple drugs or many more drugs for our patients, and then we'll have to answer the question that how can you go one step further than, okay, you have this disease and you have these 10 options or 5 options, but I have no idea which drug will be good for you versus the next patient. So I think this is what personalized medicine is, the new holy grail, I think, in all medicine, and I think Professor Sidiropoulos will be discussing this. Thank you all for your attention, and thank to the speakers.